Okay. All right, I'm calling the meeting to order. It's 5 p.m. This is Kittitas Valley Hospital District Number 1.
For what date?
Okay, what?
For what date?
This is for August 24th, 2023. That's the date. So I called the meeting to order. So should I approve the agenda, or should you call the names and get everybody that's here?
I think we're good on the roll call. We've got everyone.
You got the roll call already?
Yes.
Okay,
Dr. Hoppy's online. I see.
okay. All right, so we should approve the agenda items to be pulled from the consent agenda or anything else.
This is the, did you want to add anything? Add anything or you?
Is there anything we need to add to the consent agenda or anything else?
Not consent, just the regular agenda. I move to approve the agenda as written.
Second. Okay, moved by John, seconded by Bob. All in favor, please say yes.
Aye.
Yeah, aye.
Aye, and all against it, please say nay. Okay. All right.
Do we need to mention anything about an excused absence for Erica, or was that already handled in the last meeting?
Oh, I don't see Erica's not here.
Yeah, she's not here.
Okay. Okay, all right, so there's just 4 commissioners here. That's it. Okay, so we approved the agenda. Now we're going to discuss the consent agenda. That starts on page 3 and ends on page 14.
Make a motion, we approve the consent agenda.
I will second the motion.
A move by Bob, second by John. All instead, all please say aye.
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 All opposed, please say nay. Okay, it was 100% approved for. Okay, so now it's public comment time. If you have a comment, please say your name, your address, and do it for 3 minutes. And we don't respond at a public board meeting, but we do want your information. Any public comments? Okay, I guess we have no public comments. So now, thank you for at least listening to me. So now we're going to move down to reports in the dashboard. So the first item we're going to start with is Mandy Olson, the Chief Quality Officer. He starts on page 15 on this.
And I'm sorry, it's a little short, but I'd take any questions you have. Otherwise, I don't have any additional comments.
I'd like to mention one thing, if it's all right. Mandy and I sat down and had a really good conversation the other day about the QAPI plan and some new expectations for that. You don't need to know anything specific about it now, but in coming months, there'll be some conversations about that in QI Council, and we'll be bringing some of this to the board. So the QAPI plan may look a little different, but I think there's some exciting changes, and I think that Mandy has some really good ideas for us. So I look forward to that.
Is there somebody from the public listening to us? The QAPI plan is a quality improvement plan that the hospital puts together. That's what the word QAPI stands for.
Mandy, I know it's awfully early, but if you have anything to add on that, just a sentence or two, might be good to mention to the board.
Yeah, well, I have to give credit where it's due to. This was Julie also really pushing us to think strategically. And one of the changes will be including the budget process. So making sure that we're budgeting for this important improvement work, and also thinking about, instead of really narrow focused on departments for each QAPI project or plan, thinking more strategically. So this is even further incorporating our strategic plan into our QAPI. And so we will probably have a smaller number of QAPI plans or projects, but everyone will be involved in a QAPI project, and they probably will look very similar or be the same as our strategic projects, which makes sense, right? That should be our improvement work is part of our strategy. So I'm really
Yeah.
excited about it.
And
But it
and
will
as I
be-
say, yeah, we'll go into more detail in coming months, but I just wanted to give you sort of a heads up on it. And thanks, Mandy, for meeting with me the other day and talking through some of this stuff.
Anything else you want to talk about, Mandy?
So,
It's starting to see Linda go. I mean,
Oh.
she's done a-
Yeah, I wanted to thank her for all of her time over the years.
she has agreed to help out a little bit as we transition to in person. I don't have someone hired yet, so I am starting to feel a little, she's one person I do feel is like kind of irreplaceable. It's taking like 4 people to cover all her work.
Yeah.
So are you implying September 7th is not a hard stop date? She still might be appearing here beyond that?
Strong limits about how much she will come back and when. She does need to be there for her family,
Yeah.
so. But it'll help us have a few more handoffs, so that I'm confident we'll be able to fill the positions we have. Have great applicants. It's just that timing, it takes a little while, so.
Okay, does anybody have any specific questions for Mandy? Okay, we'll move on to the next part of the reports and dashboard. The Chief Executive Officer, Julie Peterson, hers starts on page 23 on the document.
Yeah, so Tuesday of this week, we met in the Yakima Canyon and did some clinic strategic planning. Commissioner Davis was there with us. We had Stacy and Scott and Amanda was there. Trying to think who else. Jason was there. We had Dr. Hibbs, Dr. Martin. Tony Clayton was there, and I just want to call out Tony is great to work with, great to work there. Tricia was able to join us for some of the day, but it was very, very productive. A lot of work got handed off. I'm happy to say that I was not one of the people who got handed work, so, but a lot of really exciting things, and I think we did a lot of the work, prepping for the next week's coffee meeting with the clinics, but some real enthusiasm there. I would just remind everybody that accounts for about 100,000 touches this year. So,
I thought it was very productive.
good. So a lot's going to come out of that work, I think. So, and I will just remind you again, and Stacy's probably tired of hearing this. She's been in that role since I think April of 2022. She was handed, this was one of the first things she did coming into the role was the strategic planning. And so many of the things, the MA development coordinator, the BSR development coordinator, hiring a nurse leader for the clinics, the improvement work on the telephones and scanning, so many of the things that came out of that meeting just a little over a year ago are already underway, and I missed rapid access, and I can't believe I missed it. So just an extraordinary, that our clinics have been incredibly nimble and just really patient-facing in the work they've done. So I look forward to what they're going to do next year. I am going to see if I can put Tricia on the spot. OB hospitals were here at the same time that we were in the Canyon doing clinic strategic planning. So Tricia led a lot of that work. Do you have any comments on that, or? Okay, all right. Everything I hear was very, very positive. They met with the team in the OR, they met with Family Birthplace, they had a lot of time with the clinics.
Oh, yeah, I was able to accompany them and spend some time with them in the morning with Tricia, just talking about the program as a whole. And then accompany them on the tour, and it was very nice. There was a physician lead and a nurse lead, and they both, just their eyes and smiles when they saw, the OB department, when they talked with the staff. It made me very, very proud. So I think it's going to be a very nice relationship, and I look forward to working with them and bringing them on board.
Everything I heard was
Yeah,
very, very positive.
very complimentary on
Are
us.
there any remaining logistics to sort out? Who's
Oh, yeah.
gonna do what? And so that's still.
Oh, heavens,
Yep.
yes.
Right.
There's
You didn't get
definitely
that done in the day and a
That's
half?
right.
And they spent, at lunch, I left them and they went over to the clinics. So yeah, there's definitely logistics, and I know with Trisha, on board, we will get through it all.
And they officially start full-time when?
So
Or is it-
we're gonna start matching them about mid-October. We've got polls to fill, but by mid-November, they believe they'll be on the ground and running. So just in time for the holidays, we will not have to worry about staffing OBs. So that will be-
They also were able to meet with Shannon Carlson to touch base with her, with Catherine, our physician recruiter, who's the recruiters. They will work together, and Ellen from Cerner Informatics. So-
And so will there be a fairly large contingent that rotates through and will settle on a solid group as
Yes,
the
yeah,
dust settles and stuff?
exactly. That is exactly
So
right.
the-
Same, very similar with the hospitalist
Okay.
group. But then we should have a core of, 3 to 4, 4 or 5.
They talked anywhere between 3 and 5, and what we're excited about in the clinic is they are gonna be doing GYN surgery, so they can see the patient and then schedule that surgery for the next time they come
Have some
back.
continuity for the patients
Yes.
themselves that way, so that'll be good.
I have a quick question. When we did the OB Gemba the other day, one of the questions that came up was whether we would still be recruiting for OB providers now that we've contracted with this group. I wasn't sure the answer to that. I would assume no, since we'd have a stable OB.
You are
contingent.
correct.
Okay,
So we will not be recruiting for physicians at this point.
all right, thank you.
If a physician was here and left, would we fill that spot? Or would that then be absorbed, the responsibilities be absorbed by the new group?
That's correct.
Okay.
And that's similar to our approach with emergency associates of Yakima. So we honor our commitment and love to have folks hang around if they already work here. But if they leave, I think logistically it's easier for the company to manage it.
I will make I did the Gemba solo. I didn't make the morning one, but just the can-do attitude of the staff. Like, hey, we know we're busy, but we're gonna do our best, and we're gonna service our community. And I mean, they were all like, we're gonna get there.
I think their biggest concern is that this message out there, the questioning in the community about whether we're gonna go forward with the OB program. And I know at the barbecue the other day, I had a chance to talk to some of the staff about that. They have some very creative ideas for a float, all of which Michelle has vetoed in the name of good taste. So it was, they had all sorts of things they wanted to do on a float, and we said,
This
no,
is for the parade?
yes, for the parade, and so we decided maybe
I
not.
can only imagine.
Yes, we can only imagine, so, and Michelle just stood there and said, no, we won't be doing that, so, anyway. But you're right, I mean, attitude, and that's true in family birthplace as well, they're like, they like what they're seeing, they like the message of consistency and not having to worry about, filling those holes.
One of the things that I think we've learned from the partnership with Evergreen and with Yakima Emergency is they're better able to recruit to a number of sites and to a job than we are to get a small nucleus of folks. And so to your question, John, I think that's one of the, yes, we are going to respect the work of the people who are already here, but when it comes to replacing them, I think our partners do a better job than we do for these hard to fill positions. We do a really good job in primary care.
Thank you.
The other thing,
Go ahead.
the chief financial officer, if the earth didn't move under your feet when you read that, Jason will be stepping into the chief financial officer role. We are very, very fortunate. Scott is going to be here at KVH in a senior director of revenue cycle role. So he will be out squeezing our services for every dime we can get out of them, and working very closely with the clinics, with the charge master folks, with patient access here in the hospital. So we look forward to that. Here in Hospital District 1, Scott's final meeting will be next month. So we will bring a resolution to name Jason Adler as the treasurer for Hospital District 1. That transition will occur at the end of the year for Hospital District 2 and the foundation.
Yeah, I saw the accounts receivable days ticked up a little bit, and I said, boy, I wish we could get someone good in revenue cycle. And what do you know? There we are.
That's gonna go stamp those extra days out of.
I mean, since 2018 though, our ability to chase this, even the small stuff has been significant. Small things end up being big things by the end of the year. You've done an amazing job with it.
There's additional opportunity.
Yeah.
You've been a really great CFO for us.
Yep, well, thank you.
Yeah, because your reports are always very clear and they tell us a lot of information about all the stuff going here. Thank you.
Good group that I work with.
Yeah.
And in case you haven't heard this story, Libby Alga, who was Scott's predecessor, is temporarily up at Revenue Cycle, helping out while we backfill for Kelly. We will have Scott here. Jason will be here. I am a former CFO. These are my people. So I mean, this is like, we have more CFOs running around at KVH, so we will get this done. So, the Upper County is dealing with some messaging issues. The reason that table is in here. And looking at doing a levy next year in August of 2024. So really starting to plow the ground, but I thought this was a fascinating table about the increase in taxes that the fire districts will be collecting. Both of those fire districts went out for a levy lid lift and passed those last year. But in addition to that, there's just been a tremendous amount of growth, particularly up in Upper County. So, and I finally found a way to get Hospital District 1's taxes in the same, on the same page as the rest of them. So I am happy to answer any questions.
So does anybody have any questions about Julie's report?
I mean, I like that table. That's a pretty stark contrast.
82% increase in fire district 7.
Yeah.
Yeah, and I mean, just the raw numbers of taxes to be collected.
Amazing.
I'm sure our $10,250 goes a long way.
Well spent. Evergreen anesthesia, it's going well, they're settling in. And is it, the turnovers in surgical units, does it help with some of those efficiencies? I mean, more throughput, or it's too early to?
I would say it's too early to.
Okay.
Plus we have a lot of occasions right
Yeah.
now. So, but I, go around touching base with folks down there. They're all very happy with the folks they're working with, easy to get along with, readily available when they call them, true both in OB and back in surgery as well.
Any other questions about Julie's report? Okay, we'll move on to the next person, Mandy Scott, the Human Resource and Staff Development. Hers starts at page 24. Does anybody have any questions about her report before she starts?
Is Amanda on?
Question, I mean, turnover is just universal everywhere, right? Because unemployment's so low, people are just always looking for something different. I mean, that seems like a high number, but it's just the reality in almost every sector.
Yeah.
People are shuffling around.
Yeah, I actually just went to a conference. They talked about the great return instead of the great resignation, and they're seeing some movement and actually some really interesting statistics that I could have put in here, but they actually are doing some employment surveys, I think, out there in the field now, showing that people are looking to maintain employment with their employers and possibly return to previous employers. And I did put some information in here about kind of the travel costs. We've decreased that by about 50%. And so we're seeing some movement in a lot of areas with recruiting. But yeah, it is still a challenge. And that's the rest of my report is hopefully, talk about some of those strategies that we're working on constantly to help improve that. So
So was that a national
It was actually through the Hub organization, which we do have some services with, but they're well-known in this area and they did.
So we got a good pulse on.
Yeah, I don't exactly remember who the survey vendor was, but it was a great presentation. I went to do that last Thursday and it was some good news, at least for employers around some trends they're seeing in the workforce, but each community is different. Again, our strategies around our apprenticeship program and we're going to be putting in an FTE request for a CNA patient care technician. That's one of our hot jobs right now. Program, so that should be coming soon.
We don't have any right now.
Uh,
Stevie?
We do, they're, for us, they're called patient care technicians. So
Okay.
they do a little bit more than that. But we are really we've had such success in the clinics with those development coordinator positions that we really want, and we've reduced turnover. If you look at the physician presentation that Dr. Martin and I did, we actually did more turnover data broken down by MA, RN, some of those licenses. And we have had some good success in those areas when we look at some of those hot job areas, but overall turnover, you do see that. And we are tracking more exit interviews, really trying to understand that data more, and we've increased that quite a bit, but that takes a while to sometimes really summarize and understand that data. The trends haven't changed drastically with some of the exit interviews that we've seen. But yeah, it's a complicated topic that it touches pretty much everything that we do and a lot of the areas that I'm working for. So thank you for your comments on that. Yeah.
Thank you.
And I'll just say around the clinic strategic planning, those coordinator positions were really key as we went through the survey of patient safety. I mean, having those resources and knowing, they're already doing that work and, defining some work for them. That truly has been a really, really successful transition. And I really look forward. PCT is something Steve will tell you in the emergency department back in MedSurg, family birthplace, everywhere. There's so much turnover and it's really disruptive. So we'll bring those same tools in-house.
I was actually able to set up an appointment for us. We do have a meeting with some folks from the health professions area at Central as well. So just again, a nice check-in opportunity. We have that set up for October that we're going to be talking about some of our key needs in healthcare and a collaborative program with CWU based on some, I think, conversations that have come up around nursing workforce as well. So.
And I had a quick question about the evade training that you mentioned in an email recently. As I understand it, you're suggesting that if we are interested, a 1 4-hour training, is that right?
Yes, that's correct. To attend the training with the participants.
Okay. If board members attended that, would we be in the way? Would we take a spot away from someone? Would it cost the hospital more money? I'm just trying to understand how much of a burden this would be on the organization.
No, because we actually do have some people that aren't able to make it due to staffing reasons or whatever. So I did look into that after we last talked, and while we do have a lot of people we need to get through, we absolutely can get you guys on the schedule ahead of time. That's no problem at all. And we pay by the class.
Okay.
And so when the facilitator comes, we kind of pay an invoice and the hit for his whole visit here. So we'd love to have you guys come. I think my recommendation, because I know originally we were thinking about observation versus participation, it would just be to sit in as a participant, just like the rest of the group, and be able to experience the full training. And I think you'll get a lot out of it. We also, in October, did talk to our facilitator, Patrick, and he's going to be here during the board meeting time frame that week. And so we've talked about doing a little update with him and inviting him to the board meeting. And we thought that'd be a really great opportunity to talk about our partnership and what we're working on. And he has great data on the industry around workplace violence and security and a lot of trends around healthcare. So.
Okay, we'll be going
thank you.
for how long?
KVH training?
Yeah.
He comes quarterly, and so we schedule new hires in now automatically.
For a year at least.
Yes, so if you can't make this time, that's no problem. We'll do it on a quarterly basis and we announce those dates. So you can we'll keep in touch with you, and if you're interested, and Terry can let you know when he's coming back and get our schedule set for 2024. So.
Yeah, this is going to be a permanent program, I think, from my perspective.
Yeah.
It's really good for new hires, but the refreshers.
And we've now
Thank you.
added Absolutely, yeah, we've added specialty things like home health training. They did the walkthrough through the ER last time, which was great. We've done walkthroughs with the clinics, so we're due for an active shooter training again, which was really great. So each time he's here, we kind of add something personalized for those staff that may have concerns or want additional support.
Just related to the temporary labor and the very good trend that we have right here. This is really encouraging. The other factor that's not quite as obvious is that where we're using temporary labor is primarily in the hospital, where it's basically cost reimbursed, so it cost settles. We've eliminated most of the temporary labor that was at clinics and
All of it.
home health and hospice.
All of it.
All of it.
No temporary labor.
So anyway, so although it's still number you don't want to see, but it's actually where
Neutral.
yeah. So it's even.
Although at least we can still fill the need for labor, even though it's temporary labor.
Amanda, on your top box employee population, help me again with the math, because you have, like, for example, July, 512 full-time, 110 part-time.
It's the per diems, yeah, we have.
Oh, so the per
yeah.
diems are that,
Yeah.
so we don't, okay.
And the difference is the per diems, and maybe I should just add a line to make that clear, because it is something I track. We do have quite a few per diem staff that are very helpful. But we really have a goal of trying to keep them engaged and working and regularly.
And are per diems different than the temporary labor we're talking about?
Yes, yeah, per diems can be temporary also. Temporary is more based on the time frame, so 6 months, 12 months, that kind of thing.
Kind of a long-term
Yeah.
contract sort of
Per
thing?
diems can be ongoing. We just ask that the directors look every 90 days to make sure that they're actively working, because, you know, if we only have somebody that's listed as an employee, but they're only available to do their biz library training every year and their evaluation, they're not really, able to really participate. So the directors have actually done a lot of great work. We've had a lot of conversations about, it's a give and take, the per diems, one challenge is they may not always be available, and when we do call them and have an urgent need, they might not be available. So trying to anticipate what their schedule looks ahead of time so we know when they're available, I think has been really successful. So
And the time to fill is kind of going down a little bit.
yeah, it's going down. Our applicants have gone up for a lot of positions. So the challenge with the averages is sometimes it's a really good thing when you see a high average. And the reason why is because if we have a position that's been posted a really long time and we fill that's been open, that average will be high because of how long it took to fill the position. But that means we just filled a really high needs position. So the average is a little difficult with that. When you see an outlier of a high number, that can mean that we had a position posted for a really long time, that good news we filled. So,
Well, and one of the things you guys have really focused on is once we have someone hired and they're through the, reference and drug screening, they get them to work really quickly.
Yeah.
So do pretty much concierge orientation.
yes, every day almost.
And get them on the floor, get them with the patients as quickly as possible so they can get oriented.
On the benefits side, you got a note about the change to dental consistent with the medical model. What does that mean?
Yeah, so last year, we collapsed the tiers of our medical, if you remember. So we had like all these different broken down by 0.5 FTE different rates, and we simplified that and we reduced the amount to our employees significantly. So 0.75 was our new target for full-time employees to get those benefits. We did not do that on the dental side at that time. The savings were much, incremental, I guess, compared to the medical, which was much different in rates. But we are going to match that, so it's consistent. This committee, and then we also are really excited, which I could talk about more in my next report if there's interest. But there was a collaborative program that was developed for rural hospitals in mind, a white label dental program that's through our same provider, WIT, Washington Health Insurance Trust. And it looks like it's going to be significant savings, no impact to employees, only beneficial with services. And so the benefits committee also support us to move towards that dental model, which will be more of a back-end savings thing rather than a change for employees that they would experience. So that's another exciting thing for dental as well.
Does anybody have any other questions for Mandy?
Thank you.
Yeah, let me just comment, the only thing different that I added this time was this flyer about our Alta language access, which is really exciting. I think it was about a year ago that we got the grant for this, and now those participants have now gone through the program. So you can read more about that, of course, but we now have certified folks that expand language access in Spanish to our patients, which is really cool. So hopefully you'll hear more about that as we develop that program.
And the medical interpreter is the higher level.
Yes, yeah.
Right.
We actually had a full circle example of this out of quality, which was fantastic. We were able to pull one of our interpreter staff to help us translate some patient communication materials with quality. So that's in the works, but it was a great opportunity to use those folks. So
Okay, anything else, Mandy?
thank you for your questions.
Any other questions from Mandy's report? Thank you very much, Mandy. That was really wonderful. Okay, now we're going to move on to operations. And Dee Dee, the Chief Nursing Officer, yours starts on page 27. Any questions about Dee Dee's report before she starts?
Can I just add that Tricia had commented that the visit went well. We are already working hard on the implementation of this project. Our providers were happy for the OB visit, so.
Problems with your microphone. Yeah, so thank you. The report, we've already discussed a few things. I think the one that jumps out at me, I love the quote that Amy Krogstad had given about Dave Sworry stepping into the sterile processing manager title. He's just a wonderful employee that we have. We're really looking forward to the expansion project and what he is going to be doing in his area with Central Sterile. And then, of course, for the emergency department and urgent care, I had wrote that we were continuing to work with HR to replace the ED director. And we are a little over 24 hours out of having an acceptance by an internal candidate. So we have got an ED director, Cody Staub, accepted to the role. And many of you may know him.
Look at this succession.
Yes, and just another great succession story. So I'm really excited. I know he's ready. He's nervous, which I think is good. And I think he's going to learn a lot and he's going to bring a lot to our department. So look forward to working with him and transitioning more off of my plate and onto his.
Should we have to do a big board presentation next month?
Well, you know, he would do it. I don't know, he's not listening, but I know he would do it. So let's give him a little bit of time.
Okay.
Otherwise, I think we talked about a lot of the other things that I had
How did
written
you
up.
feel about the DMV summer school?
What an energizing day. In fact, I caught Matt on the way out and asked him if he had gone through the booths, but it was just so wonderful to see the energy and networking and to see people outside of their usual home base. I think all the booths were phenomenal. Mandy just won a DNB, what is it? I think was really important. So it just very, very exciting. And I know right now, our clinical educators are working on getting the makeup PowerPoints up for everybody who could not attend.
All right, any other questions for Dee Dee? All right, well, thank you, Dee Dee. That was really great. I know one thing that was really great, the barbecue they had yesterday was really wonderful.
I was gonna let Michelle talk more about it, but yes, Jim and our dietary team did a phenomenal job.
Okay. All right. Okay, any other thing else? Okay, we'll move to number 2 under operations. Rhonda Holden, the Chief Ancillary Officer. She starts at page 29 on our documents. Any
Right.
questions for Rhonda?
Why don't you let her give her report?
Hi. So, yes, my report begins on page 29. And my first topic there was 47 degrees north. And I did get a copy of the letter that our attorney, Jamie Carmody, filed on behalf of Hospital District 1 and District 2. So he made the cut for the August 21st deadline for making those comments, which was great.
Rhonda, I just wanted to let you know that we did get that letter, the board members, so I was able to review that too before the meeting, and probably some of the other board members have too. Thank you for
Great.
that.
Yeah, wonderful. I wanted to let you know he's still working on our behalf, so I appreciate that. Underneath imaging, we talked about the contract negotiations with ONRAD. And we did go ahead and sign that contract with them. We felt like we were at a point where we really didn't have an option with them. They've just incurred great expenses related to locums, and we can certainly relate to that. We feel the same pressure using locums. The costs are going up and up, and just the cost of the radiologist salaries. And, you know, they are trying to onboard additional radiologists for us. I think we have 3 coming in tonight. So hopeful that we're going to have a little bit better partnership with them, especially regarding our turnaround time metrics and just an ongoing relationship, and negotiations hopefully will be a bit smoother. And we can also just continue to look and see what's out there as far as other partners go. Which so far, there aren't very many partners out there that have the capacity to take on our radiology reads, is what it's looking like for us. For home health and hospice, we are really, really busy with our electronic health record implementation. When I wrote this, we were just in our discovery phase, but we've actually moved past that, and they started the build today. So Michelle, April, and I, and some of the nursing staff are in meetings, probably 4 to 6 hours, a couple of times a week. Plus, we have tremendous amount of spreadsheets that we have to fill out with data and send back in. So it's been pretty fast and furious. And at the time I wrote the report, we had only hired 1 RN, but we did successfully hire a 2nd RN. So we're pretty happy with that staffing. I do still have a traveler there because I have 1 nurse out on FMLA, and my 2 new hires are going to take quite a long time to train. And for a while, with this electronic health record implementation, we'll actually be charting in 2 systems. So our productivity is going to go down until we're able to transition all patients to the new electronic health record and have everybody up to speed on how to use it comfortably. So this should be the very last time that I have to renew that traveler, and then we'll be fully staffed. Under rehab services, we are in the process of kind of looking at our contract with Rehab Visions. Their rates haven't been raised in several years. They've actually gone down since we signed the contract with them. I do think that's contributing us not being able to hire physical therapists, and also maybe a little bit in the resignation of our occupational therapist that we just had. So more to come on that next month. I think that's all the updates that I have. It's just very, very busy in my departments, and everybody's working really hard.
So any other questions for Rhonda regarding her report?
Well, always interested in the 47 degrees north. There's like is the city council leaning a certain direction? They haven't really showed any cards, or?
They do not allow their council members to talk about it, based on the advice of their attorney, I'm quite sure. But the candidates who are running, which Matthew Lund, he's a council member running for mayor. And because he is running for mayor, he has been able to voice his stance, and he is against 47 degrees north. And I think he has a lot of people behind him, and I expect that he will win the mayor's race.
Is he a strong mayor or a weak mayor as far as the council?
The one who's running, or the one who's there now?
Well, just like different city council, like Ellensburg has a weak mayor because they're just voted on by the city council itself.
Yeah.
They
I
don't-
think Cleveland
just-
has a strong mayor.
Okay, okay,
Because you actually vote for mayor in
Yeah.
that community.
yeah, that's good.
Yeah.
So Rhonda, on rehab vision, so we have a contract with them. They then have to fill these spots, but what you're noting is because the contract has certain financial limitations, they're not able to recruit as widely because they can't offer as much because of the contract. Is that the gist of what
Right.
you're saying?
Yeah, I
And-
think they're below market rate. And so HR did kind of do a salary survey for them to say, here's what's happening in the area, whether it's a KVH employee or like we don't employ CODAs, the occupational therapy assistant, but they looked at Milliman to say, here's what our market would be if we were hiring them. And so that then maybe they can adjust their wages to be more attractive to a candidate.
And on that same topic of vendors with the ONRAD, so we've just completed an adjustment to that contract. And that was, how long does that contract go for? This is a mid-cycle adjustment. We weren't at the end of a contract. We just needed to make an adjustment midstream. Is that?
It would have been over at the end of the year. So, you know, it's a good time frame for negotiations, but what wasn't really great is that they gave us like a 5-day notice, like we want your answer within 5 days. So Jason and I had a really good meeting with them and just really talked about partnership and how we value our contracted providers. And we really want to have a relationship with them more as a partner, and how can actually we help them if they're struggling in collections, or they're struggling with insurance companies wanting to cover in network or refer people to freestanding imaging facilities. We don't have those in our area, so we can kind of help on the insurance side. So we really did have a good conversation with them about that. So I felt much more comfortable after the conversation.
So you feel they were responsive to those ideas, like going forward to try to, you know, participate in those sort of solutions?
Yes.
Okay,
Yes.
great. Thank you.
Yes.
Any other questions regarding Rhonda's report?
Um,
Do you have another question?
Yeah, the Beckman chemistry analyzer, how's that come along?
It's great. I need to get some pictures of it. So they're in the process of validating the studies. So they actually have both pieces of equipment hooked up down there. And it's nice to see that the lab is working the way we had it designed so that it could be flexible and have the space to do that. So yes, I'll get you some pictures and get that in my next report. And when it's finally all done with the validation, we'll have you down for a Gemba.
Excellent. And the staff that's working down there, they appreciate what this piece of equipment's gonna be able to do? I mean, it's fitting in well with their plans for running the lab?
Yeah, they're very excited about it.
Good, thank you.
Yeah, great.
Yes, thank you.
No other questions for Rhonda regarding her report? Okay, so no other questions. We'll move down to number 3 under operations. Stacy Olay, her chief of clinical operations, and her report starts at page 35.
So we are excited to say we are seeing our deliveries for the month start to run in the upper 20s. I think the highest number I've seen so far is 27. So we're opening that up and the patients are coming probably just by word of mouth to start with. So we're really, really excited to get back on track with the OB program. And I'm sure all the CFOs in the room are happy too. I'd like to point out that pediatrics did receive a grant, and this is for integrated behavioral health for pediatrics. So we're excited to see how much funding we actually get and what we can do with that. The mental health in peds there's definitely a high need to be able to offer this service within that clinic. So we're excited about that opportunity.
I just want to thank Dr. Young, Megan Young. She was the one, I think we had 48 hours when she found this grant out there before the grant was due. So we stuck Megan and Mitchell Rose together in the room and are looking at probably $200,000. So, but Dr. Young was the one I think that identified that opportunity for us.
And then reach out and read. So for the first half of the year, from January 1 through June 30th, that we gave out 880 books to children at their well child visits for the first half of the year. So next month, I hope to have statistics of the entire amount of books we've given since the inception of that program. I think it's a great program. If you look at the dashboard, I want to let you know regarding new patients, my goal for next month is to actually be able to break that out by clinic. So when we look at primary care and you're switching primary care within KVH, we do not charge you a new patient visit. But if you are a KVH primary care patient and go to see a specialist, there is a new patient charge for that piece in that specialty clinic. So my goal is to be able to provide some information by clinic so you can see where these new patients are actually showing up. I'd be happy to answer any questions.
On the Gimba, they were showing me the ability to monitor real-time a patient over here from his office and even from his cell phone.
Mhm.
And that is huge.
Should have come to your camp.
You interrupted their line.
I know.
I mean, I just can't imagine you could watch a couple different and see their blood pressure and all this data in real time.
That's the feed-on-link monitoring. Yeah.
Yeah, the technology is just incredible.
Yeah. Great.
Thanks for inviting Barry and Matt and I to the MA apprenticeship graduation kind of program. It's exciting to see people going through that program and starting on their medical career, if you will, getting their foot in the door that way. So
I think we've got 5 more pending their exams, so more partying soon.
just let us know. Anytime there's cupcakes involved, we'll be.
Well, it's really good with the MA that you're doing, because that's a real foundation of our healthcare, having the medical assistants there. They help all our other providers do a lot more work. So thank you so much for making our foundation a lot stronger by getting them on to us.
You're welcome. The other piece that just noticed with the MA apprenticeship program is it really has helped us with standardization throughout all the clinics, because you've got students going through and they'll be like, oh, well, that's not how I saw it done over there. So it gives us some opportunity to address some training issues.
So I'm one of those patients who had to establish primary care with a new provider. And Angela Bennett was in charge of the short straw at Family Medicine Ellensburg. And I will just say, Wendy is my new provider over there. And as I was chatting with her MA, it was Jamie, who's one of the new apprentice grad. And I just kind of went, wow, this is so cool. And what a team. I mean, they're absolutely wonderful. So again, a plan coming together. So.
Wonderful.
So on dermatology, we have.
Go
ahead, Matt.
Oh, sorry to interrupt. Just one more thing on the MA apprenticeship program. And I don't want to over celebrate or anything, but at some point it might be nice to celebrate the people who are training them, because they're just so proud of the work they do. And I think it's great, obviously, that we recognize the people who go through the program, but the people who are making it function, who are actually working with the people who get the MA, go through the program. I've talked to some of them, and it's just, they're beaming, they're so proud, and they're so excited to be part of this program. Might be nice to get all them in the same room at some point and kind of celebrate the work they do too. I don't know if that's something for Michelle or somebody else, but.
Maybe included as part of the end of the year recognition, call it out, the preceptors.
That would be wonderful.
Yeah.
I think that sounds like a great idea. Yeah.
Go ahead, John.
Thank you. Sorry.
On the dermatology side, we have somebody currently who's going to like supervise. Is that the way it's working?
We do have a physician who is supervising dermatology, and we are also in an onboarding stage of a potential.
And so that was going to be my next question. It looks like we might have somebody who might
Yes.
physically actually be able to
Yes.
be here on
Would be a
site.
full-time provider.
Provide, okay. And you'll know in the next month or so how that's panning out? Or?
It's probably.
Okay.
We have a signed letter of intent, so we would expect that we would have the second provider onboarded fairly shortly.
And is the signed letter, is that them sign it and give it back to us? Is that what that means? Signed letter of intent?
Any other questions for Stacy?
Rapid access, Saturday's still the kind of the slower of the days.
It was, but we
We'll be road
actually have seen 14 sports physicals on the calendar. And then Michelle pushed out in social media that we're doing sports physicals as a walk-in on Saturdays.
Oh, excellent.
So we're looking.
Proving
at that.
effective to.
Yes.
Okay, excellent.
Well, she just pushed it out, so
Yes.
hold on Saturday.
Might be understaffed on
Yeah.
Saturday now.
Sports physicals are always so hard to get in for, so
Yeah.
we think we made, and you reached out to all the schools, so we have all the
Mhm.
forms and so.
And is the timing, because fall season's coming up, a lot of the sports are just starting
Season,
up.
yep, and it's right around the corner. And if you haven't done it, I think they've got a deadline maybe of next week to get it in.
I've had several members of our community go through the rapid access, and they said it was very functional, and they were able to get very good health care out of it. So it was really good. Julie and everybody wanted to put their rapid access in, that it's able to support members of our community that are our patients.
And then I would also just say that what Julie noted earlier is, just the amount of work and things you brought to fruition and the time you've been there, I'm just really proud of it and amazed at what you're doing. So.
There's a
thank
lot
you.
more coming.
Yeah.
Good, good.
You're almost rapid accessing the rest of our hospital. Any other questions? No, okay, so now we're going to move to number D under reports and dashboards. This is about the medical staff. Our chief of staff, Roberta Hoppy, would be the first one. Her information is on page 39. Dr. Hoppy?
Yeah, good evening. We had another pretty busy month credentialing new applicants. As you can see, we had 13 candidates up for initial appointment and 2 reappointments. And most of these applicants were from the emergency medicine group out of Yakima and several from the Evergreen anesthesia group. And so these files were reviewed and approved by our MEC committee. And Dr. Thomas attended that meeting on my behalf. And then the second page, on page 4, you'll see there's a new set of delineation of privileges for our new tele-nephrology group. And this was also approved by our MEC committee. So if anyone has any questions, I'd be happy to answer them.
And Dr. Hoppy, do we need a motion on the delineation of privileges, or is it just for our information?
I think we need a motion, actually.
Okay, so does anybody have any questions about this draft for the delineation?
And I think we should do the credentials first. I was just asking.
Oh, you want to do the credentials first?
Yeah, go in order.
Okay, well then I'll back up to page 39. So,
Sounds like Bob was making a motion.
Yeah, I make a motion to accept that.
okay, so
And I'll second on the credentials unless Matt wants to jump in.
Okay, John.
Okay, thank you.
Bob made the motion, John second. So all in favor, please say aye.
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 And all opposed, please say nay. Okay, 100%. We've disapproved all the new medical staff appointments. Now we'll move over to the delineation of privileges. Do we have any questions regarding this at all? Okay,
Any
so the
experts on
question-
telenephrology in the room?
Yeah, I can speak for them. It's a very straightforward, correct way to go with this.
Yeah, I looked it over. Thanks, Dr. O'Brien. Appreciate it.
And Dr. O'Brien, this would allow us to keep some patients in our hospital here that currently we have to ship out if they have this issue.
That's correct.
Thank you.
All right. Any other questions regarding the delineation of privileges?
I'll move to approve the delineation of privileges.
Can I have a second, please?
I will second.
Okay, moved by Matt, second by John. All in favor, please say aye.
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 All opposed, please say nay. Okay, 100%. Dr. Hoppy, that was 100% approved.
I
Dr. O'Brien.
I want to thank Dr. Martin. He's been working on this. Besides behavioral health patients, this is the single largest group of folks that we have to transfer out of our emergency department. That doesn't even count the patients who already know we don't provide this service and are bypassing the hospital. So I think this is really going to meet a need in the community and keep fragile patients who already have a lot going on locally.
Will we have a way to spread the word once this is up and running, or?
Michelle and Dr. Martin, I'm pretty sure they're working on it.
And this concludes my
Let
report.
me
Thank you
just-
very much. No.
Let me just add that these are high acuity patients, which is good for our bottom line.
But also is good for them, so they don't have to travel as far for this service?
Yes. So one of the things that was driving me was I had a friend who was a dialysis patient here in the community. And whenever he got sick, he knew better than to dial 911. He went straight to regional because that's where he could get dialysis. And we're not talking about patients with new dialysis. This is right now, anybody who is a dialysis patient and has any other condition shows up in our emergency department, and it's an immediate transfer.
Okay.
Yeah, thank you, Kevin. That's great work.
And one last thing, if I can add to, this is going to dovetail really nicely into our vascular program as well, because many of those patients with vascular issues need dialysis kind of acutely or semi-acutely when they're undergoing procedures. So I think it's going to complement the vascular program nicely as well.
Good, thank you.
Exactly. Yeah.
Anything else? All right, so under the medical staff, we'll move to number 2, the Chief Medical Officer, Dr. Kevin Martin, and he starts on page 41. Dr. Martin, you're up now.
You have my report and have heard much of my stolen thunder. I'll take any questions.
Any questions for Dr. Martin? All right. Thank you, Dr. Martin, for the wonderful report. It was really, really nice reading it. So now we'll move on to number E, the Finance Chief Financial Officer, Scott Olander. His report starts on page 43. Go ahead, Scott.
Thank you. If you would turn to page 45, you will see the critical statistics that are driving the financial revenue. And lines 1 and 2 are admissions and patient days were below budget. And so when we turn to the financial statement, you'll see a significant variance in inpatient revenue. Moving on down to line 7, as Stacy had mentioned, we had one of the best months of our year for obstetrics. We delivered 25 babies in July. Down on the surgery and ER lines 11 for inpatient surgeries, line 12 for outpatient surgeries, 13 for GI procedures, and 14 for ER visits. Our surgery volumes were better than budget for the month. They've typically been running at a 40% positive variance, and so they were at just over 20% positive variance on surgery. So we're not quite as busy as we had been in surgery, primarily just due to the provider vacations. ER continues to be very, very busy, drives a lot of revenue. Imaging is much of the volume coming to the emergency department needs scans, and so line 17 imaging is over budget by 14%. And then line 21, observation days, was in excess of budget, and much of the positive revenue variance in outpatient you will see is as a result of the outpatient surgeries, ER visits, and imaging. And then just due to vacations, our total clinic visits were below budget for the month. They're basically just slightly below budget year to date. We're trending at just over 1,500 more visits in 2000.
Just out of curiosity, since often vacations happen at a similar time of year, when we do budgets, do we ever drop for a month or so knowing that a lot of providers might be gone or?
We really don't. We sort of do, but not so
Kinda
much
just-
because people, sometimes it's July, sometimes
just don't
it's
know for
August,
sure,
sometimes it's September. Yeah,
Yeah.
it varies.
Okay.
So our budget for the most part is straight line.
Okay.
You know, it's still interesting that historically, even though we budgeted based upon the growth of our clinic visits, they're still a lot larger than they were several years ago. When you talked about that at one of our other meetings, it was interesting to see how the clinic visits have really increased. A lot of it probably has to do with the baby boomers out there, since they're getting old enough that they need to see a clinic a lot of times.
Well, the other two items that Julie would normally comment on, maybe I'll.
No,
go ahead. Lines 36 and 37. Operating expenses per adjusted patient day. Low budget is a good thing. It means we're quite efficient in our expenses, even though we'll have some negative variance when you look at the P&L. But overall, efficient. And then the same with lines 37, operating revenue per adjusted patient days.
I was over here scratching in the margin, and I just want to say, you know, we've been kind of looking at this change in surgery between inpatient and outpatient. But when you look at year-to-date budget of the combined, they are exactly 34 minutes off. So kudos to Jason and Scott and Amy Krogstad. So either that or they're cooking the books, one of the two.
Good budget.
Good budget.
ER visits continue to go up.
Interesting meeting that we had this week, and I'm sorry, I meant to talk about it when Dee Dee was making her presentation. We sat in a room, you know, there is not an expansion on the books yet for the emergency department because we've been so steady for so long. And, you know, about this time last year, we started seeing volumes go up. So Cody and Dee Dee and Dr. Schmelzer and Dr. Martin were there. Who am I saying? Ron, I think Trish might have been there. We are all convinced we are headed to 70 patients a day in the very near term, up from 30s just a year or so ago. So they're going to be doing some really creative thinking about how we can deal with that in the next 3 to 5 year timeframe, since we don't have anything on the books for an expansion. It'll, you know, improvements in throughput and how we manage supplies and things like that, but it's going to be really challenging.
It'll be interesting to see how rapid access impacts that, or if it does. And I'm sure it will, I just don't know how much.
It hasn't yet,
Yeah.
which is.
Do you have a comment on line 19 about the outpatient percent of total revenue? Because it's over what we budgeted for.
That's really just the shift from overall inpatient to outpatient. So it's just a higher percentage, but we had budgeted based on what we were seeing last year. And if you look over to the prior year, we were at about 84.9% was the outpatient revenue as a percent of total. So really it's just a 6% shift from inpatient care to outpatient care. And some of it's increases in ER volume, some of it is a shortfall in obstetrical services that we've done this year because OB is a delivery as an inpatient by definition, so that's impacted us. And then also the Longo is his total knees and hip procedures, for the most part, are done as an outpatient rather than an inpatient. So, combination of factors.
One more quick aside. Dee Dee, do we know how long on average a patient stays in the ER?
We do have that data. It depends what the disposition is. Our, discharge home, it's usually those couple of hours, hour and a half to 2 hours. And that's been holding steady. If anything, it may be decreasing just a touch.
Okay.
Admission 4 to 5 hours, 4 hours.
If they're being
Trans-
transferred into
and
the
then-
hospital.
Yeah, so that's going to our inpatient. Transfers out is very variable, whether
Yeah.
you have your mental health, behavioral health patients, it can take unfortunately days, or just looking for specialty care. We have been having to hold a few medical patients just because we can't find an acceptable
And that's
facility.
occupying
And that's-
a bay or a bed
Yeah.
during that whole time. So.
And that's the kind of thing, really, I think Dee Dee started talking about this a few months ago. We have patients, the doc's been in and seen them, asked for a number of lab tests and diagnostic imaging tests to be done. Now the patient is just waiting for results and a consult back from the doc. If we could move them out of the traditional emergency department room into like holding type, more maybe even joint room where people are just waiting, that's.
Free
the
up
sort
that
of-
room for
Exactly.
active treatment
So
or something.
That's the sort of solution we're looking for in the short term.
Also, I think strengthening our partnership with the hospitalist group and then having our inpatient nurses and our ED nurses working on that process, I think we can shave time there. As long as we have that physical bed
Yes.
on the other end of the building.
Important details. So.
Yes.
So, sorry, Scott, for the
No,
deviation.
no. Any other questions about the stats portion of it? Then let's move over to page 48, and let's see what it did to our statement of revenue and expenses. As forecast, significant negative variance on inpatient, $943,000 shortfall. The trend continues on inpatient. We're below budget by year-to-date $5,145,000. But we made up for it on outpatient for the month. We're over budget by almost $2 million for the month. Slightly in spite of being the clinic's below budget, our pro fees were over budget. Some of that is because of ER professional fees. But over budget for the month, we're over budget on revenue by 1.275 million. And then over year to date, you see on outpatient revenue a positive variance of $10.6 million. And then over budget year to date by $6.8 million. So you see some of the growth continue that we're experiencing. Another line that I think is really quite significant that has improved in the last couple of months is other operating revenue. We're over budget this month by $71,000 and year to date by $19,000. In the last 3 months, and this is work that Nasser and the pharmacy team have been doing, we're recapturing some of that additional contract pharmacy revenue. And then also our outpatient pharmacy has been over budget on revenue, as has cafeteria. And so some of that $71,000 positive variance in other operating revenue is due to those factors. So we started this 340B ESP program, which is a bit of a hassle, but Nasser and his team are doing it, and it's resulting in some additional 340B revenue for the organization. And expenses, all in all, you saw that we are over budget on expenses by $328,000. Slightly over budget on temporary labor for the month. That's still the biggest piece was professional fees, and that was there's a chunk of about $130,000 for the evergreen anesthesia, and then we have locums for OB, internal medicine, pediatrics, and there's probably
That should be it.
I am also.
Internal medicine.
And but this is just a needed expense that we have to have. So we reported a positive operating income of $343,000 for the month. The year to date, we're positive just over $2 million. Our non-operating revenue, we had a good month. We had an investment mature, and which we booked that income, and then we had interest income on the LGIP funds. So a nice net of $710,000 for the month.
year-to-date, $3.7 million.
And then we're gonna have to return any of those profits, or that's all kind of analyzed at the end of the year to see?
Because of arbitrage.
Yeah.
Maybe a little bit,
But
but.
not significant about
I wouldn't say so. Don't really talk too much about the balance sheet, but this month, cash popped up and investments went down, and the investment we had matured at the end on July 31. And so it flowed from the investments up to cash and then reinvested on the 1st of August. So the cash was up about $2.5 million over what it has been, and investments were down by about the same amount.
Did you get a good rate on those investments?
It was 4.7, I think. It was
better than the previous round.
um,
I mean, where that investment came
this
from.
this particular investment was a good one. It was a 4.5 or something
It
like
was a
that.
short term.
It was a short term, and so there's a few more other ones that'll get fixed. Hopefully, it'll be here.
Those 0.14s.
Yeah.
Yeah.
Those are just painful now.
Yeah, they're painful. Stacy still Mitchell's thunder on the grant, but we're grateful for Mitchell and Dr. Young to get that behavioral health for pediatrics. The only other thing, any questions about the finances? And then I have a capital request related to nephrology and dialysis.
And Dr. Hoppy just mentioned dialysis during one of her discussions earlier, I think. So this is going to be very supportive of what Dr. Hoppy was talking about previously.
So as Dr. Hoppy reported, we have a contract with a telenephrologist, a nephrology group. And Trish and Dr. Martin have done a lot of research and we've got a couple of dialysis machines that will support acute inpatient dialysis or acute outpatient dialysis. It's not routine. It's only acute patients that have an acute need to be here at the hospital. A surgery patient would be a candidate, the patient of Dr.
These are the ones where they had to be diverted. They couldn't come here if we didn't have this solution.
So they can be moved around from one.
Yep, these are portable machines, and we would likely have one physically located in ICU and probably another one in med surg.
I think they'll both be kept down probably on the inpatient unit, as far as storage, but the goal is to train staff, and we'll have a core group of staff.
So it takes specialty training to operate this. Will that be a limiting factor in us being able to use it to start? Or how long of training is this sort of thing?
Well, right now we're meeting weekly, and I know Trish is probably still on the call. We're in the talks of what that training looks like, because we will be sending nurses off site, but there's also some training they can be doing virtual. We'll have partners come here. We're looking at doing an open house just to let the nurses explore this option and see who wants to kind of sign up first.
Explore it as an option to add to their skill set, so to speak.
Right, so I liken it to our SANE nurses and to our PIC team nurses. These are,
Training is 60
yeah.
hours with certification.
one
Thank you, Tricia.
of these is a 40-hour offsite
Okay.
training that we will have to send nurses to.
So with the specially trained people, will they also then maybe be available for call? Because I don't know
Yeah,
that immediately
that's
we can cover
where-
it 24/7.
We're gonna have to explore how we're gonna roll that program out.
So the use of these machines would just be on the med surgeon in the ICU. It wouldn't be in the surgery or the emergency department.
Correct.
Or
Yeah,
over-
most
or over an OB.
likely, I would think, at least starting it in that ICU area where it's a controlled, room, but we could do them on med surge.
They'll go where they're needed based on the patient. I would assume.
There's a little bit of plumbing involved
Yeah.
with
And
the room, and it's not particularly expensive, but it's just to set the room up and
the
the
time
water
of the
source.
procedure, so that's where we don't want to tie up that, ED room.
But this will allow community patients to be able to get a lot more stuff done here. They currently,
And again, these are for the patients who would need to be admitted to the hospital. so it's not as a.
We're not going into the outpatient dialysis.
Correct.
business.
So
Sure, go ahead.
just for a little historical perspective, the first dialysis machines were made out of modified washing machines back in the 50s. And they've gotten more streamlined. The equipment that INSAT uses, they are saying that it will do for dialysis what the iPhone did for cellular communication. The machines self-diagnose. They mix their own diacylate solutions. And again, to Dee Dee's point, with some training, which INSAT provides for our nursing, we can do this totally locally with existing personnel and extend a service to our patients.
Trisha mentioned in the chat
And
too.
I'll
that there-
guarantee you that, let me guarantee you that the nurses in the ICU will be very excited and happy to do that.
It says that dialysis will be only during daytime hours, and the med surg and CCU areas will have 24/7 access to the nephrologists, and that they're also provide on-site and online training.
And did you have any more? I had some questions about this, but anyway.
No, just this is, as Stevie said, this is, you know, I see on transfers out, there's at least 2 to 3 transfers out every month for patients that are coming to the ER. And there's some that are already bypassing us automatically. So there's probably, I'm guessing, perhaps 4 to 5 additional admissions per month that will result from this, having this training with the nurses, this equipment.
So this will really help us increase the wonderful care we give to our community here.
And this cost is for 2 machines.
This is for 2 machines.
What's the anticipated lifespan of these machines? And what are the reoccurring costs? Is there a warranty, ongoing expected maintenance? Like some things, you know, it's going to cost X thousands per year to maintain it. Any sense of that?
She said 5-year lifespan, we're expecting up to 4 additional admissions per year.
Per
Per
year?
month, per month.
I think that was 40.
It says EYAR.
Was there a
It's
zero?
probably
I
per
read
year.
that as
Probably
year,
per
but-
year. 40 per year.
Yeah, I think it was 40. I think there was a 0.
Oh, there's, yeah. I think she's typing as fast as she can.
And the life is a function of use too. So there's, these they'll be used, but they're not gonna be used on it.
So in theory, their life could be longer if they're in use 24 hours a day. Probably not.
She's saying 40 admissions with 1 to 2 runs per admission.
So you're looking at 3 to 4 nights stay.
And we're looking at amortized, like 20,000 a year for the equipment for the 5-year lifespan. So,
It'll be a nice return.
Yeah.
So will the patient require a little vascular surgery so that they can have access to the machine?
These patients, most of them will already be patients that are having routine dialysis already. So they'll have the fistula and the, is it fistula?
Yes. Yeah, there's fistulas, and then just the catheters.
Right.
And so that's some of the training that the nurses need, is how to access them.
surgeons can do. As
And-
many, so she says medical people here can also create the access points.
That's some of what Dr. Zamet does. Yes,
But our surgeons can also do the access, as can the ED docs.
But for the most part, again, these are the patients that with pneumonia that happen to be dialysis patients that we would transfer simply because of the dialysis, not because we couldn't treat the pneumonia. And now we'll be able to keep them. That they'll have existing access for the most part.
Okay, that's great.
Yeah.
Okay, so any other questions before we vote on this?
You want to entertain a motion?
I will entertain a motion. Can I get a motion for to approve this?
Go ahead, John.
Bob, first did it. I will allow Matt to second it, or I'm happy to second it.
All right, second.
Get him on.
Bob, move, Matt Sutton. Okay, all in favor, say aye.
Aye.
All opposed, say nay. Okay, it passes 100% again. Great, so now so when do you think these dialysis machines will show up?
We were talking about this today. They were thinking pretty quickly once we get the order in. And Tricia may know, because as soon as we receive the machines is when we're gonna have the open house for the nurses with the team here to help answer questions.
Allows them to see
And they were
what this
talking
can
like
do,
next
and
month.
then they can decide whether or not to do the additional training.
1 month from today.
Yep.
Needed your approval.
Well, that's wonderful. So any other questions regarding Scott's financial report?
I just want to say it's been tremendous to work with you as CFO, and I'm so excited that you found a position that keeps you here longer, and I think does something you're really passionate about too, as you kind of slow down a little bit in life. So
Yeah, but I'm glad we still have you in our
Thank you,
lives.
Scott, for you've taught me a lot during the few years I've been part of the finance committee, so thank you.
Yeah, okay.
I agree.
Okay, and nothing else? Everything good? Thank you,
The
Scott.
only other thing I will say is Jason Adler is on notice. This is the last fourth Friday of the Thursday of the month
And he gets,
that he will be gone. So you want to know if he had to come tonight, and I said, you should take this one.
Enjoy
Never
it.
again.
Okay. All right, so we're done with finances now. We're going to move on to the next item, Community Relations Report. Michelle Worrell, our Chief Public Relations Officer, her report is on page 57. Michelle?
Hey, everybody. I would just like to reiterate, go back to the barbecue that we had on Wednesday. It was absolutely fabulous to get back to inviting the community and having all of the staff together. We moved it over to the south side of the building this year due to construction, and the feedback we've received from that is it was actually a very good change. People enjoyed that location. Weather was gorgeous. We had Dr. Prenoyer providing music. John Terry, thank you very much for being there and welcoming the community. We raised just over $250 for the foundation, thanks to people that were willing to get a little bit wet underneath the dunk tank. And it was just a wonderful event. I've got my team reaching out to the women's health team. So everything from Family Birthing Center to the clinic to the fourth trimester, trying to work together for a great float or participation in the parade that doesn't necessarily put us on the front page of the newspaper. And other than that, I don't have anything to add. I'm welcome to take questions.
So Michelle, can you talk a little bit about the planning we just started today for the 13th legislative?
Sure can. Yeah, so we would, WISHA has asked us to make a point of communicating with our legislators on a regular basis. We have a good relationship with the 13th legislators, and we've worked with all of them in the past. Representative Ybarra has helped us in the past receive some funding. So we're going to try and get together with them on a quarterly basis. We kind of look at what's going on statewide, and then we also look at what's affecting us in the county. So we really, we're hoping to get together with them in September. Mandy is working on a date, and we're looking at things such as the issues that we're still facing with maternal health, mental health, and how that's affecting our care, both in the emergency room and throughout the system. Looking at that, I will be talking about workforce staffing and some of the creative ways that we're using to try and address that, such as like the MA apprenticeship, the pharmacy refill program, things like that. And then really kind of having some discussion about so much of the talking points that we hear from WISHA are about the big systems and what's happening there. But all of that affects us downstream. And so talking about what that means, you know, the delay in transferring patients, the increases that we're seeing in RED because of things that are going away in Yakima, like vascular and GI. Talking about adding the inpatient dialysis, exactly like you guys were talking about before, keeping patients closer to home so they don't have to go someplace. And the restraints that the insurance companies are putting on that's really making it more difficult for patients to receive care closer to home. So those are some of the things that we're talking about. We're hoping to have about an hour of their time each quarter. And we'll be reaching out to you guys to share some of that time with us. Maybe like rotating through the board and who wants to participate and things like that. So that's what's going on.
How have the farmers markets events been received by the public?
Great. Alicia has put together a whole schedule for the year and those topics. She's getting a lot of interactions. I don't have the numbers right in front of me, but she's tracking them. Some real positive feedback. One of the things we were talking about experience healthcare one weekend at the farmers market, and some older adults were talking about, well, how can we learn more about the hospital? And Amanda and myself and Alicia and Kyle were talking about that today, and we're thinking about, using feedback like that to finally have an open house for the MAC, for example, and invite people in for more of a not really hands-on, but to see what we're doing, to see what the office is, what services we offer there, to check out the building, to meet our staff, and then doing the same thing next summer, fall, when the expansion opens. So that being said, we're getting great feedback, great participation. I think the staff are really stepping up to the plate and helping us man those things. So Alicia isn't there every weekend. It's been good.
You could tie, the MAC and rapid access together.
Absolutely.
Yeah.
Absolutely. That one, our plan on that one is just, we're waiting until the lab move is taking place. And then once that's done, once we get a schedule on that, we'll move forward. Anything else?
Any other questions for Michelle? So the barbecue was a really great community relationship. John and I were people taking tickets, helping them to get services at it. And there was a lot of really great community members there. Plus our employees came in too, but there was a lot of family members came in and had barbecues. So they were very happy with it.
So many people volunteered. Andy was on the grill, Scott was on the grill. Julie was all over the place you got dunked with an umbrella, you had covered an umbrella that got so wet. So that was fun. It was great to feel like people are getting back and socializing.
Felt so good.
And the weather couldn't really have been more ideal. The smoke had cleared and it wasn't too crazy windy.
Yeah, and Phil, who also works in our kitchen here, was also on the grill. He's a really great cooker. So anyway, because he did some education on how to be a really great chef, and he was a really good person managing the grill. So that worked out really good. So thanks, Mandy, for your support on that. Any other questions? Not Mandy, I'm sorry, Michelle. All right, well, now we're going to move on to education and board report. So on page 58, there's some information about State Hospital Association's annual meeting in October. And I'm on their governance committee for the Washington State Hospital Association. And I did hand out a little paper here because I did some little research on governing board safety and quality, but that'll be something that we'll be discussing at the meeting. And if you would like to see a copy of this, Mandy could probably get a hold of you. These were a lot of things about governing board and safety and quality that I was able to research on the internet. And then I'm going to be meeting with their Daisy, who's their vice president, who oversees education for Washington State Hospital Association for safety and quality. And then at our next meeting in September, I might have some little more information to be able to tell you people about safety and quality because that's something that the governing board gets to oversee, because we have Mandy Olson tell us all about safety and quality because she's our quality chief. And so consequently, we're able to do a lot of things to increase safety and quality it's even like the dialysis machines we just bought are going to be increased safety and quality for the organization. So consequently, that'll be something that being a governance board, that's what we are, the commissioners, it's really good to be able to oversee it.
And then for the board members, if any of you would like to attend that annual meeting, just please let me know.
When do you want to know by? Is there just by their deadline here?
I don't remember what their deadline was off the top of my head. I think it was September something, but just. when you
Deadline
know
to
is-
reserve a room is September 29.
Okay.
Yeah,
So when you know would be great before they fill up their rooms.
and I will be at that meeting because of being on the governance committee. So, I guess we'll move on to the next thing. We don't have any old business. Does anybody have any new business that we should be talking about?
What was some of this stuff that was handed out? Do we know?
One is the letter on 47 degrees north.
Okay.
And then also, we have some new material, it's a really, really nice hospice and Terry's summary.
Okay,
So
thank you.
Okay. All right, so our future meetings for this board in September will be on the 28th. And October, it'll be on the 26th of October. But since Turkey Day, Thanksgiving in November always kind of gets around our meeting. And so we'll have a special meeting probably in the beginning of December, like we've done historically. And then our December meeting will be historically in January of 2024 at the beginning of the month. So is there any other thing? We don't have an executive session today. So if there's nothing else that we need to chat about, we can adjourn the meeting and get home a little bit earlier tonight. Do you have anything to say, Matt?
Nope. Thanks for handling it, Terry. Appreciate it.
Okay, all right. And nobody else here? And I'm glad we were able to have Scott at this meeting. So thank you again, Scott. for being a
I'll be here next
wonderful
month
person.
too.
All right. Okay, so I am adjourning the meeting now. Meeting is
Thank you.
over at
Thank you.
6:32.
Thank you, everyone.
Good night.
Okay.
Awesome team.
So did I do, okay, John?
thank you, everyone.
Yeah. Did, you think I discussed today? Properly?
I think again, it's, you put it out in the public. Thank you, John.
We'll see you next month. We'll see you. Finance.
You know, the thing is really funny.
Yeah.
Matt, I looked up the quality insurance in council. But.
Are we still, can we stop recording?
Hey.